Good afternoon. This is Dr. Ajit Singh. I'll be talking about antifungal agents and guidelines. First of all, we'll revise the classification of antifungal agents. Then we'll try to understand the pharmacological properties. Then we'll try to learn important antifungal therapies used in the ICU settings and their drug interactions. And then finally, we'll look into the evidence in the treatment of fungal infections in various subsets of critically ill patients. Now, first of all, the morphological classification of fungi. Fungi are divided into yeast, molds, or dimorphic fungi. The yeasts include Cryptococcus and Candida. They are monocellular organisms that divide by budding, so forms pseudohyphae. Molds are multicellular organisms. These includes Rhizopus and Mucor. Then dimorphic fungi. Dimorphic fungi are those which can exist as yeasts or molds at different temperature. It includes histoplasma, blastomyces, coccidioids, paracoccidioids, and aspergillus. Now, the timeline of systemic antifungal drugs. The first case of cryptococcal meningitis was discovered in 1925 in USA. The first drug was developed. The first antifungal that was developed was nystatin, that was developed in 1955. The first Pauline that was developed was amphotericin B deoxycholate that was isolated from Streptomyces nodosus in 1960. The first azole was developed in 1990, that was fluconazole. The first echinocandin was developed in 2000, that was caspofungin. And the last to be discovered is isovuconazole that was discovered in 2015. Now, antifungal can be broadly classified into polyenes, imidazoles, triazoles, allylamines, echinocandins, and others. Now, there are four main classes of clinically used antifungals in the treatment of invasive fungal infections. The first being polyenes. They inhibit cell membrane formation. These are fungicidal. They are broad spectrum and the resistance is rare. Then coming to flucytosine, it inhibits DNA and RNA synthesis. It is fungicidal and it is almost exclusively used for cryptococcal meningitis. Then azoles, they also inhibit cell membrane synthesis. These are fungistatic. These are broad spectrum and the resistance is developing fast. Now, the fourth one is echinocandins. They inhibit cell wall synthesis. These are the first line of defense for Candida and used in aspergillosis. The resistance is low, but it is emerging. Now coming to the individual drugs. First of all, amphotericin B, it binds to ergosterol in the cell membrane, thus forms micropores. It disrupts membrane permeability, thus leads to release in ions, electrolytes, and glucose, thus leading to cell death. It also leads to accumulation of reactive oxygen species, thus denaturation of enzymes, thus leading to cell death. The clinical indications are Candida, Cryptococcus, Aspergillus, Histoplasma, Blastomycetes, and Zygomycetes. It is available in 4 formulations: deoxycholate, liposomal amphotericin B, lipid complex, colloidal dispersion. Then dosing for deoxycholate is 0.7 to 0.5 to 0.7 mg per kg. For others, it is 3 to 5 mg per kg. It is more than 95% bound. The metabolism is hepatic and the excretion elimination is feces. T-half is 50 hours. It can cause nephrotoxicity, renal tubular acidosis, anemia, dyselectrolytemia, and infusion-related reactions. And amphotericin B deoxycholate, that is conventional amphotericin B, is available as 50 mg vial as yellow powder, reconstituted in 5% dextrose. The dose is 0.5 to 0.7. It is more nephrotoxic as compared to the other preparations. It is preferred formulation for intrathecal injections. It is to be avoided in patients with cardiopulmonary compromise. Then coming to the liposomal preparation, lipid preparations. First is liposomal amphotericin B. It is reconstituted with sterile water. The blood levels achieved are equivalent to those achieved with conventional amphotericin B. For amphotericin B lipid complex, it is more nephrotoxic as compared to liposomal amphotericin B, and the blood levels achieved and the blood levels of amphotericin B that are achieved with lipid complex are lower than that achieved with liposomal amphotericin B or conventional amphotericin B. Now coming to the susceptibility of amphotericin B, it is quite high. The resistance is quite low, but the resistance is increasing with the increase in the number of Candida auris cases. Now coming to the azoles, the first one is fluconazole. It inhibits ergosterol synthesis by blocking demethylation of lenosterol by inhibiting 14 alpha demethylase, thus inhibiting cell membrane synthesis. It also leads to formulation of a toxic metabolite that further leads to the damage. The clinical indications are candidiasis and cryptococcus. Then it is available as capsule, injectable, and suspension form. The bioavailability is good. The dose is 400 to 800 mg per day. The protein binding is 10%. The CSF penetration is up to 90% of the plasma concentration. So used in CSF meningitis, CSF fungal meningitis, and then the metabolism and elimination is hepatic and renal. T-half is 24 to 36 hours. The dose is to be adjusted in case of renal dysfunction with creatinine clearance of less than 50 ml per minute. It can lead to transaminitis, headache, and alopecia. It is an inhibitor of CYP3A4, 2C9, and 2C19. Then coming to the second one, itraconazole. The clinical indications are histoplasmosis, blastomycosis, and aspergillosis. It is available as capsule and solutions. The dosing is 200 to 400 mg per day. It is more than 95% protein bound. The metabolism is hepatic and the elimination is feces. T-half is 30 hours. The toxicities include hypertriglyceridemia, transaminitis, skin rashes, GI upset. And since it's a strong CYP3A4 inhibitor, it can lead to QTc prolongation. Now coming to voriconazole, the clinical indications are candidiasis and aspergillosis. It is available as injectable suspension and tablet form. The bioavailability is 96%. The dosing is for first two doses, 6 mg per kg IV or per oral for 12th hourly, followed by 4 mg per kg IV or per oral every 12th hourly. It is 58% protein bound. The metabolism and elimination is hepatic and feces. Dose adjustment is needed in case of hepatic dysfunction, that is child PUG class C or beyond. In case of patients on ECMO, its dose should be increased because of circuit sequestration. T-half is 6 hours. The toxicities includes visual toxicity, hepatotoxicity, QTc prolongation, altered mental status. Since it's a strong CYP3A4 inhibitor, it can lead to QTc prolongation. Its IV formulation contains cyclodextrin component that can cause renal toxicity. So should be used cautiously in case of patients with decreased renal functions. Now, osaconazole, the clinical indications are aspergillosis and mucormycosis. The formulations are injectable, suspension, delayed release tablets. The dosing is for first two doses 300 mg twice daily for first two doses, followed by 300 mg once daily. The protein binding, it is 99% protein bound. The metabolism is hepatic and the elimination is by feces. T-half is 20 hours. It can cause hepatotoxicity and GI upset. Since it's a strong CYP3A4 inhibitor, it can cause QTc prolongation. Now coming to isoconazole, the clinical indications are aspergillosis and mucormycosis, available as capsules and injectable. The dosing is 200 mg 8th hourly for 2 days, followed by 200 mg once daily. It is more than 99% protein bound. Metabolism is hepatic. Elimination is feces. T-half is 80 to 120 hours. Can cause hepatotoxicity. Since it's a moderate CYP3A4 inhibitor, can cause QTc prolongation. Now looking at the antifungal susceptibility testing in Candida. Antifungal susceptibility in Candida. If you look at Candida albicans, it is fairly susceptible to fluconazole, itraconazole, and voriconazole. For non-Candida, other than glabrata and cruzi, all are susceptible to fluconazole, itraconazole, and voriconazole. Candida glabrata and cruzi, these two have inherent resistance to fluconazole. So, in case we are suspecting these two, we should give either itraconazole or voriconazole. Now, if you give azole along with cytochrome P450 inducers, it leads to decreased azole concentration. If you give azoles with cytochrome P450 inhibitors, it leads to increased azole concentration. If you give it with cytochrome P450 metabolites, it leads to increase metabolite concentration. So in all these cases, you'll have to do the azole levels. Then into echinocandins, the mechanism of action is it interferes with 1,3-beta D-glucan synthase, thus leading to cell wall formula disruption. Then the indications are candidiasis, and it is also used as a salvage therapy in invasive aspergillosis. Now the dosing for caspofungin it is 70 mg stat followed by 50 mg OD. For micafungin it is 100 mg stat and 100 mg once daily. For enidulafungin it is 200 mg stat followed by 100 mg daily. Enidulafungin is 84% protein bound, and the rest two are almost 99% protein bound. The metabolism for enidulafungin is chemical degradation. For the other two, it is hepatic. The elimination for caspofungin is renal. For the other two, it is fecal. The TR for caspofungin is 30 hours. For micafungin, it is 15 hours. And for enidulafungin, it is 26 hours. We'll have to adjust the dose for caspofungin in case of moderate hepatic dysfunction, that is child PUG B or beyond. Then a susceptibility profile of echinocandins in Indian perspective is the isolates are susceptible for echinocandins, especially for micafungin and enidulafungin. The susceptibility is more than 95%. For caspofungin, it's a bit low, but still it is very high. But with the increase of Candida auris, the susceptibility is the resistance is increasing. Now coming to anti-metabolite, flutocytosine is converted into 5-fluorouracil inside the cell that leads to interference with DNA formation, the cell death. The clinical indications are cryptococcal meningitis and Candida cystitis. Available as capsules, the dosing is 25 mg per kg every 6th hourly. Dose adjustment is needed in case of renal dysfunction. The protein bind, it is 4% protein bound, so it is used in fungal meningitis. The metabolism is hepatic. The elimination is renal. The T-half is 3 to 4 hours. Toxicities include bone marrow suppression and GI upset. Then we have discussed about Candida albicans and non-albicans with regard to azoles. Now, Candida albicans is fairly susceptible to other two classes also, that is pollines and echinocandins. For non-Candida albicans, these are also susceptible to echinocandins and pollines, but non-Candida albicans, that is parapsilosis, that has developed resistance for echinocandins. So in that case, it should be used cautiously. Preferably, the susceptibility testing should be done. For Cryptococcus species, amphotericin B, it is susceptible for amphotericin B and azoles. For zygomycetes, it is also susceptible for amphotericin B, osaconazole, and isoconazole. Cryptococcus and zygomycetes, they do not have 1,3-beta-glucan in their cell wall, so these are not susceptible to echinocandins. Now, the most commonly encountered invasive fungal infections in the ICU patients are in the West are Candida aspergillus and pneumocystis. In India also, if you look at a data from a tertiary care hospital, Candida accounts for almost 85% of the cases, among which 24% are Candida albicans. Rest 61% is non-Candida albicans. Aspergillus accounts for 3%, Cryptococcus mucor and Trichosporon 1 each. The same was replicated in a multi-center study by Chakrabarti et al. The Candida albicans accounts for almost 20%, 21%, and the rest is by Candida non-albicans. And among Candida non-albicans, it is the Candida tropicalis, which has the highest share. Something of concern is the rise of this bug. This is Candida auris in last few years, because this bug is highly resistant. Now, a few words about Candida auris. It is developing resistance very fast. It is easily transmitted. It can cause rapid colonization and contamination of environment. Once it colonizes, very difficult to get rid of it. Then its infection causes high mortality as compared to the other Candida infections, and it is not easily identified. by simple phenotypic methods. It needs multi-end sequences. Now, the first reported case was in 2009 from Japan. Now, almost 32 countries of 6 continents have reported Candida auris infections, and India has the highest number of cases. Now, if you look at the susceptibility of the isolates, they have developed resistance to amphotericin B for almost 36% of the cases. For fluconazole, it is as high as 80%. For voriconazole, it is as high as 22%. If you look at echinocandins also, the resistance is quite high. That is 19% for caspofungin, and for enrolofungin, it is 17%. The lowest being with micafungin. So if you have a case of suspected Candida auris, better start the empirical therapy with echinocandins, preferably micafungin. Now, the odds of developing an infection, developing an invasive fungal infection in critically ill patients is highest with the patients having a central line and broad spectrum antibiotics, followed by total parenteral nutrition, diabetes, steroids, colonization at one or more sites, then Foley's catheterization, chemotherapy-induced neutropenia, burns, abdominal surgery, neonates, and hemodialysis. There have been a few scores that have been developed, but they have a very good negative predictive value rather than a positive predictive value. So we should use them for avoiding to use antifungal therapy when it is not needed. Now, antifungal treatment strategies. First of all, prophylaxis. If we have risk factors of developing a fungal infection, then we give a therapy to prevent the infection, that is known as prophylaxis. If we have clinical signs and risk factors, we start something called empirical therapy. If the biomarkers comes positive, this is called preemptive therapy. If we have the identification of the fungus, then the therapy is targeted. Now, coming to the surviving sepsis guidelines, they say for patients with sepsis or septic shock with high risk of fungal infections, they suggest using empirical antifungal therapy over no antifungal therapy. For a low risk fungal infection, for low risk cases, they suggest against it. Now, what does the CDC says? They say that prophylaxis could be used in high risk patients in adult ICUs with high rate of invasive candidiasis. For high rate, they have said it should be more than 5%. The treatment should be started with fluconazole, 800 mg loading, followed by 400 mg daily. Alternative is echinocandins. Daily bathing with chlorhexidine could be considered. Then role for empirical treatment should be started as soon as possible in patients with risk factors and clinical signs of shock, that is empirical therapy, and should be considered in critically ill patients with risk factors for invasive candidiasis and no other cause of fever. Like a patient who has been already started on 4 to 5 days of appropriate antibiotics and the fever is still there, or the patient who has had remission of fever and then again the patient starts developing fever, you should consider adding empirical therapy. Then preferred therapy is echinocandins followed by fluconazole. Fluconazole is only given when there is no recent exposure of azoles and the patient is hemodynamically stable. Now, the duration of therapy is if the improvement is seen and the blood culture is negative, we have to give therapy for 2 weeks after the blood culture is negative. If there is no clinical responses at 4 to 5 days, no evidence of no evidence of invasive candidiasis, and we have no cultures to support it, we can safely stop the antifungal therapy. Now, the targeted therapy for non-neutropenic patients start with echinocandins. The alternatives are fluconazole and amphotericin B. Now, susceptibility test should be done for azoles in all the bloodstream infections and for echinocandins in cases of Candida glabrata, Candida parapsilosis, or the patients which have prior history of treatment with echinocandins. Now, when do we transition from echinocandins to fluconazole? Generally, we should be able to do that in 5 to 7 days if the patient has become or is hemodynamically stable tests are the patient is susceptible for azoles and the blood culture is negative. Dilated ophthalmological examination by an ophthalmologist should be done within a few weeks after the diagnosis. Then blood culture should be done every day or every alternate day. The duration of therapy is 2 weeks after the clearance of candida from blood and resolution of candidemia. Then CVC, the catheter should be removed as early as possible whenever it is the suspected source of sepsis. Now, for neutropenic patients, the therapy to initiate is echinocandins. The alternative is amphotericin B. Now, the step-down therapy is with fluconazole. The rules are same. Then, when you need additional coverage for molds, rather than fluconazole, you have to start voriconazole. Then duration of therapy is the same as for non-neutropenic patients, 2 weeks after the clearance of candida from the blood and the resolution of the symptoms of candidemia and neutropenia. Then dilated ophthalmological examination can be delayed till the recovery of neutropenia. Generally, in neutropenic patients, causes other than CVC predominate. So CVC's removal should be on the individual basis. And in case we anticipate protective neutropenia in case of persistent candidemia, we can think of giving GCSF or granulocyte transfusion. Now, for chronic disseminated candidiasis, we have to initiate the therapy with liposomal amphotericin B or echinocandins for several weeks. Step down is with oral fluconazole, and the duration of therapy should be until the radiological resolution of the lesions is there. So we'll have to repeat the radiological examination every week. If we discontinue it prematurely, that it can lead to relapse. One more thing is we do not have to delay the chemotherapy or transplant. If the patient is having chronic disseminated candidiasis, we can continue antifungal therapy and go ahead with chemotherapy and stem cell transplant. The antifungal therapy should be continued throughout the high-risk period to prevent relapses. Then coming to oropharyngeal candidiasis, for mild cases, topical clotrimazole or nystatin suspension should be used. For moderate to severe oropharyngeal candidiasis, oral fluconazole 7 to 14 days should be given. For chronic suppressive therapy, if the recurrent infection is there, fluconazole 100 mg thrice weekly should be given. In case of retropositive patients, to reduce recurrent infections, ART is to be given. In case of denture-related infections, disinfection of dentures and antifungals are to be given. In case of esophageal candidiasis, systemic antifungals are always given. Then the trial of antifungal should be given before endoscopic examination. Oral fluconazole for 14 to 21 days is given. If the patient is intolerant to oral treatment, IV fluconazole or echinocandins can be given. If it is refractory to fluconazole, itraconazole or voriconazole can be given. In case of recurrent esophagitis, chronic suppressive therapy is given. In case of retrovirus positive patients, ART is to be given to reduce recurrent infections. For intra-abdominal infections, those patients who are having significant risk factors of candidiasis, that are abdominal surgeries, necrotizing pancreatitis, then anastomotic leaks, empirical therapy should be started as soon as possible when we have also. Then appropriate drainage or debridement is to be done as soon as possible. The duration of therapy depends on the adequacy of the source control and the clinical response. Then coming to UTI due to candida. First of all, remove the hardware, eliminate the predisposing factors. So catheter is to be removed. Then for neutropenic patients, treat as for candidemia. For non-neutropenic patients, do not treat unless the patient is planned for any urological procedures. For urological procedures, oral fluconazole or amphotericin B before and after the procedure are given. For symptomatic candida cystitis, removal of indwelling urinary catheter is done. Then if the isolates are fluconazole susceptible, oral fluconazole for 2 weeks are given. In case it is resistant to fluconazole, amphotericin B deoxycholate or oral fluconazole for 1 to 7 days are given. Then a bladder irrigation with amphotericin B deoxycholate is to be can also be given for cases of pyelonephritis. If we have nephrostomy tubes or stents in situ, remove or replace the tubes. If we have fungal balls, surgical intervention and irrigation through nephrostomy tube should be done. Then coming to Candida endocarditis, for native wall endocarditis, therapy should be initiated with liposomal amphotericin B plus minus flucytosine. The alternative is high dose echinocandins. Then step down is fluconazole if it is susceptible to the fluconazole. Then if the valve replacement is done, then the antifungals are to be continued for 6 weeks post valve replacement. If the valve replacement is not done, long-term suppression with oral fluconazole is given. In case of prosthetic valve endocarditis, chronic suppressive therapy, suppressive antifungal therapy with fluconazole with 400 to 800 mg daily is given. In case of implantable cardiac devices, such as pacemaker or IDs, entire device is to be removed, and antifungals are to be given as to be given for native wall endocarditis. Then, if the infection is limited to the generated pockets, therapy is to be continued for 4 weeks after the device removal. And if it involves wires, therapy is to be continued for more than 6 weeks after the wire removal. If the patient is having ventricular assist device, chronic suppressive therapy should be given as long as the device is in situ. For thrombophlebitis, Candida thrombophlebitis, catheter removal and incision and drainage or resection of the vein is to be done, and antifungals are to be continued till the resolution of thrombosis there. Now coming to invasive aspergillosis. First of all, prophylaxis. Prophylaxis is given in case of prolonged neutropenia and high risk of invasive aspergillosis. We give posaconazole, voriconazole, or micafungin. In case of allogenic stem cell transplant with graft versus host disease, the prophylaxis is given with posaconazole. Then in case of lung transplant, the prophylaxis is given with systemic triazoles for 3 to 4 months after the lung transplant. We'll have to reinitiate it if the immunosuppression is to be augmented. There is no strong evidence in case of non-lung solid organ transplant, so we'll have to individualize our approach as per the organ transplant and the amount of immunosuppression we are using. Now coming to the empirical and preemptive therapy. First of all early initiation of antifungal therapy in the patients with suspected invasive pulmonary aspergillosis is to be done. It should be started with liposomal amphotericin B or echinocandins or voriconazole. Generally, we should make the best use of fungal biomarkers such as galactomannan and 1,3 beta-D-glucan to guide asymptomatic or febrile high-risk patients, and it can reduce the unnecessary antifungal therapy because the negative predictive value is quite high. Now, in case of lung transplant recipients, if the patient is not on anti-mold prophylaxis, start preemptive therapy with voriconazole. Now, coming to the targeted therapy in invasive pulmonary aspergillosis. So first of all, initiate the treatment with voriconazole or liposomal amphotericin B or isovuconazole. The drug of choice is voriconazole. If the patient does not tolerate or there is any contraindication for the above antifungals, you can use echinocandins. The duration of therapy is 6 to 12 weeks, depending on the degree and the duration of immunosuppression, the site of the disease. Once the treatment is, once you have successfully treated the invasive pulmonary aspergillosis and the patient needs subsequent immunosuppression, we'll have to initiate secondary prophylaxis. We should reduce the dosage and stop the immunosuppressants whenever feasible if the patient has a history of when the patient is having invasive pulmonary aspergillosis. Then granulocyte transfusion for neutropenic patients with refractory invasive aspergillosis is to be done. Then whenever you feel the anticipated duration of neutropenia will be more than 1 week, then surgery for the localized disease, which is easily accessible to the debridement, should be done. Then coming to mucormycosis, for the prophylaxis of invasive mucormycosis in neutropenic patients or those with graft versus host disease, the primary prophylaxis with posaconazole, delayed release tablets is to be done. In case of the patients who are immunosuppressed with previous diagnosis of mucormycosis, you'll have to go ahead with surgical resection and continuation or the restart of last effective drug. Then for targeted therapy, early surgical, complete surgical and systemic fungal treatment is to be done. Then in case of brain involvement or solid organ transplant, the first line of therapy is liposomal amphotericin B. The duration is for 28 days. You'll have to assess the response with weekly imaging. If there is no response or the patient is having progressive disease or there is toxicity, you can use isoconazole IV or posaconazole IV or delayed release tablets. In case of pre-existing renal compromise, isoconazole IV or posaconazole IV can be given. Now, an entity, COVID-associated pulmonary mucormycosis, CAPM. What is it? That if you develop pulmonary mucormycosis within 3 months of virologically confirmed COVID-19, it is called CAPM. Now, what is a proven CAPM? If the patient has histology or cytology positive for septate hyphae from a usually sterile site showing growth of mucorales, then it is called proven CAPM. If the patient is having risk factors, is having compatible clinical features, is having radiological features, and you have a demonstration of aseptate hyphae in a sample which is representative and not the usual sterile site. So this is a case of probable CAPM. And possible CAPM is if the patient is having signs, it is having risk factors, and it also has radiological features, but there is no demonstration of aseptate hyphae. Now, what is the treatment? First of all, if it is a case of proven or probable CPM, start amphotericin B. Then look whether the patient is operable or not. If the surgery is possible, go ahead with surgery. If there is complete response, close observation is to be done, and we'll have to start posaconazole or isoconazole for another 4 to 6 weeks. If there is partial response, then continue liposomal amphotericin B for another 4 to 6 weeks, and start posaconazole or isoconazole after liposomal amphotericin B for at least 4 to 6 weeks after complete response. Now, if the surgery is not possible, you'll have to start with liposomal amphotericin B and reassess response at 4 to 6 weeks. If the disease is stable or progressive disease, we'll have to continue liposomal amphotericin B or salvage posaconazole or isoconazole. You'll have to reevaluate for the other causes, and you'll have to go for in vitro antifungal susceptibility. In case of partial response, you'll have to reassess the patient for surgery and start posaconazole or isoconazole until there is complete response. Now, coming to cryptococcosis, it causes meningitis in both immunocompromised and immunocompetent patients. The most common symptom is headache of insidious and chronic insidious onset. The neck stiffness is often absent, and fever is often late and low grade. It can also involve lungs, bone marrow, skin, and GI tract in patients suffering from retrovirus. Then in case of cryptococcal meningitis, the CSF count is generally less than 50, and these are mainly mononuclear. The proteins are slightly elevated. The glucose is normally normal to low. If you do only India in preparation, you will miss almost half of the cases. Cryptococcal antigen testing is very sensitive, and it is highly specific. It is done in urine, CSF, and serum. So it should be done in all the cases. And if the patient is having a high titer, it denotes high cryptococcal load. Now coming to the targeted therapy in immunocompromised patients. In patients who are in patients with immunocompromised patients living with HIV/AIDS, you'll have to start with induction and consolidation therapy with amphotericin B and flucytosine, preferably. If patient cannot tolerate, if there are any contraindications for flucytosine, we can replace it by fluconazole. So the induction therapy with amphotericin B plus flucytosine or fluconazole for 2 weeks, followed by oral fluconazole for more than 8 weeks. Then the maintenance or the suppressive therapy with fluconazole or itraconazole, preferably fluconazole for 1 year. Then in patients with in patients who are at high risk of developing immune reconstitution syndrome, the ART should be started after induction phase, at least the induction phase. If the patient develops the immune reconstitution, you will have to delay the therapy for another 8 weeks. That is for induction and consolidation phase. For those patients who develop immune reconstitution syndrome, for these patients, we should generally do lumbar punctures to decrease the intracranial pressure, and we should add high dose dexamethasone or prednisolone for 2 to 6 weeks. For organ transplant patients, for CNS disease, it is same as with patients with HIV/AIDS. Lipid formulation amphotericin B plus flucytosine for 2 weeks, followed by fluconazole 400 to 800 mg per day for 8 weeks, followed by fluconazole 200 to 400 mg per day for 6 to 12 months. For non-CNS diseases, first of all, rule out meningitis by lumbar puncture. For mild to moderate disease, fluconazole 400 mg per day for 6 to 12 months. For severe disease, treat as for CNS disease. Now, you might need prolonged induction therapy in few patients. Which are these few patients? Those patients who have received who have not received 5-fluorocytosine, they have received your fluconazole instead of 5-fluorocytosine during induction phase. For these patients, you'll have to give a longer duration of longer duration of induction therapy. For those patients who are having severe uncorrected immunosuppression, you might have to give longer duration of induction therapy. Then if the patient is having positive fungal culture, CSF fungal culture at the end of induction phase, then you'll have to again repeat for 2 weeks. If the patient is having parenchymal lesions, that is cryptococcomas and persistent symptoms, you'll have to prolong the induction therapy. Those patients which are non-HIV or non-solid organ transplant patients, for these patients, your induction therapy should be continued for 6 weeks as compared to 2 weeks for immunocompromised patients. Now, with all the knowledge we have assimilated in this lecture, what we have come to a conclusion is, for a fungal infection, look for the risk factors, suspect early, treat empirically, use biomarkers to rule out, isolate a patient if you suspect candida or other other fungal infections, isolate early, then disinfect early, and treat early and effectively. That is the crux of treatment of fungal infections. Thanks for listening. Thank you.